impression, but such studies need to have a detailed measurement of actually exercise and human activity in order to capture what is the real important part. Okay, now any other important questions or not so important questions? No, if not, I'd like to thank you again for this fascinating talk and hand over to now the next disease area and to the next speaker from Hamburg. So Insa, I'm very interested now to hear about the EBDiMS tool in MS in your special research unit in Hamburg.
Perfect, thank you so much. I hope you can hear me.
Yes.
Yes, perfect. I'm gonna share my screen. Can you see the slides properly? Perfect. All right. Yeah, my name is Insa Schiffmann. I'm a neurologist from Hamburg, and today I'm presenting results from a survey using the evidence-based decision support tool, EBDiMS tool, to answer the question, do people with MS really want to know their prognosis and how do they react to it? These are my conflicts of interest. And obviously I'm presenting, but this is not my work entirely, but led by a very smart medical student, Ricardo Koch, and also our host. Well, MS, as you well know, is a neurodegenerative and autoimmune disease in the central nervous system, affecting mainly young adults. And up to 30% of cases are benign, but it can also progress rapidly. The prognosis is quite variable, and this might be one reason why physicians often refrain from talking about the prognosis with their patients. Another reason might be that they're fearing a kind of a nocebo effect by presenting negative prognostic information, and also because it is really usually quite uncomfortable to talk about stuff like that. And that's why more than 50% of people with MS have actually never talked about their prognosis with their physician, and fittingly, 50% claim to have no idea of their long-term prognosis. This is rather worrying, seeing that obviously MS is a lifelong disease that will likely cause some kind of disability affecting young adults. And we all want to plan, and to plan we need to have some kind of idea how our life is going to look like in the next 5, 10, 20, 30 years. And not surprisingly, more than 70% strongly prefer to receive long-term prognostic information, maybe despite what physicians fear. So all in all, there's an unmet need for prognostic information in people with MS. And Martin Daumer and his team tried to fix this issue by developing the evidence-based decision support tool, EBDiMS tool. The EBDiMS tool is an online analytical processing tool, an OLAP tool, to calculate long-term prognosis in people with MS. It is using a matching algorithm to identify cases from a database that is similar to the user or like the patient in question. The calculations are based on data from one of the largest and most followed MS cohorts, the London, Ontario cohort, which in this case includes 717 individuals with a natural disease course, so no immunotherapy, and a follow-up of up to 30 years. The tool looks like this. It's a website, and you can enter, or you have to enter, the data of the patient that you want to calculate the disease trajectory for. So you enter the disease course, relapsing, remitting, or PPMS, the gender, the age at first symptom, relapses in the first 2 years. And then you get an output of expected time to reaching EDSS-6, which is a disability scale used in MS research. And in this case, it means that the patient needs, or the person with MS needs, a walking aid to walk 100 meters or more. And EDSS-8, which is the disability level of being wheelchair bound. So it might look like this. You enter that your patient is female, has a relapsing remitting MS, was 25 years age of age at onset, and had 2 relapses in the first 2 years. And then you get an image like this, The disability level is on this axis, the time to from disease onset here. The dotted line is the mean, the black line is the median, and then you see kind of different bands around this with, for example, this would be the 25th and 75th percentile and so on. And you can see that the precision is rather high at the beginning with most patients available to compare to, and then the precision gets lower and the accuracy gets lower the longer the disease course. And for example, for this patient, the expected time to EDSS would be at around 21 years, and to EDSS 8 up here would be around 28 years. So it would take 21 years with a standard deviation, something like a standard deviation of 12 years to need a walking cane, walking aid to walk 100 meters, and 28 to be wheelchair bound in this estimate. We then wanted to see whether using this tool could be useful, helpful, and acceptable to people with MS. And to do so, we performed a cross-sectional study with patients, participants recruited at the MS Day Clinic at the University Medical Center in Hamburg-Eppendorf, Germany. The exclusion criteria were obviously that they couldn't have reached EDSS 6, because then it wouldn't have made sense to do an estimate. And they were excluded if they had a severe anxiety disorder. We then performed interviews with the participants. They first answered a pre-EBDiMS questionnaire with clinical and demographic data and their own risk estimates. Then we presented them with the output that I just showed you in the previous slide, individualized for their own case. And then they answered a post-EBDiMS questionnaire with, again, giving their own risk estimates and stating an evaluation of the EBDiMS tool. And then we performed a short-term follow-up via telephone at 14 days to inquire about acceptability and impact of EBDiMS. This is our cohort. 50% were female. The majority had a relapsing remitting MS, so the most common form. 50% were taking some kind of immunotherapy at this point. Mean age was 44 years and disease duration was 9 years. Mean EDSS level of disability was 2.5, so it was a mild to moderate disability. So all in all, this is a rather typical MS cohort, except there were less women than you would expect. So usually the distribution is more like 2/3 of women. In this case, it's 1-to-1. And the disability level at 9 years of 2.5 is, I would say, rather low. However, we have to remember that we excluded participants with an EDSS of higher than 6, but still, I think we have a rather less low affected MS cohort. So maybe this is not representative, so the results are representative for the whole MS population. And you might obviously wonder, are these people, is this like, why, how could this be? We did record how many people declined to take part. So about 1/3 did not want to receive prognostic information, which is equivalent to what I showed you at the very beginning. 30% don't really want to talk about it. We did not record age or gender or something for these participants, only their main reason, which was anxiety caused by the idea of receiving prognostic information. And maybe we could argue that women who have a tendency for example, anxiety disorders or anxiety in general, maybe are less interested in receiving this information. We did ask them if they had ever talked about their prognosis before, what their experiences were. And again, like in the data I showed you at the beginning, about 65%, 2/3 had never talked about their prognosis with their physician, and 60% stated that they would have liked to receive prognostic information earlier than this at this time point that we were conducting the study. So on average at 9 years of disease duration. Well, this is the most important slide of this topic, of this talk. It's the perception of the tool. As I said at the beginning, most doctors say they are worried about the effect, negative prognostic effect information has on patients. And I think I can mostly disprove this. So these are violent plots, and the level of agreement is on this axis, ranging from low to high, and then we will go through the different questions. So understandability and interest were rated as very high. So participants found it very understandable and very interesting. They also stated that it was helpful for patient-physician encounters and relevant for coping and therapy decisions to receive this prognostic information. Most of the participants would recommend this tool to others. However, obviously, this was one thing that we were worrying about. Receiving negative prognostic information might be worrying. Imagine somebody told you in 25 years you are going to need a wheelchair. And kind of expectedly, this was the most critical area. So psychological acceptability was, let's say, okay. 57% found EBDiMS reassuring, and 43% were rather concerned. 2 participants actually needed counseling after using the EBDiMS tool. All in all, we still think that given that this information is rather worrying, people with MS actually accepted it very well, and some degree of worry was to be expected. So all in all, conveying long-term prognostic information using EBDiMS is understandable, interesting, relevant, and acceptable, but it does cause concern in some and anxiety in few. We actually did introduce a screening tool using the hospital anxiety and depression scale after these 2 patients had these acute stress reactions. So what we then asked was whether the tool estimated or the tool's estimates matched the ones of the patients, and this is a lot of columns, a lot of lines. So we will go through this slowly. On the left side here, this line is always refers to time to reach EDSS 6. The lower one EDSS 8. The orange column here shows the tool's estimates to reach EDSS 6 or 8. And the first columns here show the patient's estimates before and after using EBDiMS. So first of all, what is rather noticeable is that the tool's estimate for EDSS 6 is much more pessimistic than what the patients estimated. So there's a difference of about 3 to 4 years, which was significantly different. And it was similar for EDSS 8. The second thing that you might notice is that when you see this number, 17 years versus 21 years, then they looked at the tool, and then the result was almost the same. So even though the tool's prognosis was much worse than they actually thought, it did not really change their own view. This might be because, as I told you before, disease duration was about 9 years, so they had reached some kind of level of disability. They were able to kind of compare what did the tool calculate for my current state and what is the actual truth. And most of these participants probably were, we know we looked at it, were much better than they were predicted to be, or were feeling much better, had a lower disability level. So they probably thought, okay, so 17 years would be the average participant, but I'm obviously having a better disease trajectory, so I don't have to readjust my estimates. And the same was mostly true for EDSS 8. The third thing that you can notice is that people with MS estimated their disease course to be worse without immunotherapy and better with. Makes sense. We also asked participants directly whether how high they rate the efficacy of their immunotherapy, and on average they rated as high or very high. So all in all, the estimates of people with MS differed significantly from what the tool estimated, and EBDiMS did not significantly change their risk estimates in years. I have to say one thing about the calculations of EBDiMS. This is kind of a worst case scenario. So the data is rather old. It was collected in the 80s until 2000. So obviously the population that is arising now is different from what was looked at back then. And it was a natural disease course, so immunotherapies weren't used. So maybe if we did this with more modern data, the estimates already would be much better. So maybe the estimates of the participants were actually more correct. We did a short-term follow-up and 69% thought about EBDiMS at least occasionally or frequently. 90% discussed it with other people, especially significant others or family or friends. 20% looked for further information, were probably disappointed because there is none to be found for laymen. And degree of worry did not change significantly. So also in the long term, it did not cause any further stress. So in summary, EBDiMS was highly understandable, interesting, relevant, and recommendable, but worrying to some participants. It needs explanation and guidance, so it was explained by a researcher, and people with MS also stated they did not want to look at it alone. They wanted to look at it with a physician, actually, and with their family and friends. The estimates differed significantly from the estimates of people with MS, and it did not influence people with MS risk estimates. All in all, conveying long-term prognostic information by using EBDiMS is valuable, feasible, and acceptable. And lastly, kind of, because obviously this is not a talk about MS, but more about general topics living in the COVID-19 area and mobility and telemedicine. I would say that as a kind of takeaway as a whole, we should consider, even though that we might refrain from it, people with any kind of disease probably long need and can handle prognostic information, even if it is negative. The least thing physicians or treaters should do is inquire their preference and try to meet this need, even though we might have uncertain data about it, but even this uncertain prediction is worth a lot. And these kinds of online tools are helpful to convey this prognostic information. I want to thank all the collaborators and thank you for your attention. And if you're interested, write me an email.
Okay, Insa, thank you very much for this talk. And I may start with a comment. So for someone who has in this case, it was a not-for-profit product that was developed out of the Sylvia Loris Center, which was an international effort to collect a huge amount of data in order to improve medical decision-making for MS. And it's a dream to have now a sufficiently independent group that has used this tool and done all these carefully designed experiments. So that's because that's a difficult topic these days, whether you produce a medical device or you have other technology, to find trustworthy, independent, and knowledgeable groups that are able to assess the quality of these things. So that's a very, very healthy collaboration, I think, between Hamburg and Munich, and thanks for being part of this. Now, you've made a couple of comments, and I'd like to comment on these comments. So there was this question, well, maybe the prediction of the patients was better than the tool. I agree with you, but the scandal is that we still do not have the data that would tell us if this is true or not, although this is extremely important. Still these days, no one really knows how much the new drugs are impacting the long-term disease course. What we know is that, well, some of those drugs are killing patients because the side effects are so dramatic that people will be dying within a year or two, which otherwise they would probably not do. And so we've been trying also with the help of Christoph Hesen and your group to find funding for now getting new fresh data from Denmark, from Sweden, from trials from pharma companies, but it doesn't work. And my feeling is that there are some background wishes that people who do not want to see such data out there. And maybe there's one example that you may or may not know, because you said, well, this is a worst case scenario. So similar to what we've seen in the Max talks from the Max Planck Institute in Göttingen, to have upper bounds and worst case scenarios. And the data set from London, Ontario, well, these are all untreated patients. And they have been used as a control group in a study in the UK, a large study, which was called the risk sharing scheme. And there, a group of pharma companies agreed with the government to compare treated patients in the UK with this, what you said, worst case scenario. And everyone was sure that there is going to be a very big effect, and they had a risk sharing scheme, which means if the effect is really very big, the pharma companies would earn a lot of money. And if it's not so big, this effect, they don't earn as much money. And up to the point where the effect is very little, and then it would be very cheap. Yeah? And as a shockwave, it turned out that when they then finally, after years of delays, analyzed the data, they found out that according to the analysis plan, the treated patients did worse than the people from the London, Ontario cohort. And people said this was the most expensive expense of the NHS in the UK ever. I don't know, 500 million euros or whatever has been spent on this scheme. There has been lots of debates afterwards, but I just wanted to say this, it's still open, and it's a scandal that in this field it has not been possible to continue to have some high quality data collection that would allow to answer these questions.
Yeah, I agree. And I mean, it's always difficult to convey this information to patients because it's rather counterintuitive that you can prevent lesions, you can prevent relapses, but in the end, after 20, 30 years, you might be exactly where you would be, without the drug. Seeing that even NIDA at 2 years, for example, does not really predict outcome at 10 years, which we know from the EPIC study, does show that the effect of the immunotherapies is on MRI and relapses mostly.
Yeah.